first the imaging component, and then the transarterial treatment, which will then be followed by INSUP with transvenous treatment. Whenever I talk about a dural arteriovenous shunt, I'll try to explain it to my patients by pointing them to a kitchen sink. A kitchen sink has a faucet, a basin, and a draining pipe. And then I tell them, well, just imagine you now have like naughty kids that hook up a garden hose to the draining pipe. Then two things can happen. If the flow in the garden hose is very low, then nothing really will happen with the basin and will not overflow. However, if the flow in the garden hose is very high, then you may get backflow into your basin. So that's one way that a dural arteriovenous fistula can become symptomatic, and that would be cortical venous reflux. So obviously the faucet are the normal arteries, the basin is the brain, and the draining pipe are the draining veins. The garden hose is the dural AV fistula, or the middle meningeal artery. Now the other thing, however, the dural arteriovenous fistula can become symptomatic is, even though the flow may be very low, if your kids are really naughty, they put, in addition to like hooking up the garden hose here, some leaves and debris in there that will decrease the outflow of your draining vein. And then even a trickle, a small flow dural arteriovenous fistula can lead to problem of either reflux or, as the second problem, of decreased arterial throughput. Because no matter how high the flow here is, there is now an increased pressure within the draining system against which the artery has to kind of compete. And therefore, what we will have in patients with dural arteriovenous shunts are two different, separate types of pathological mechanisms. One is arterialization of veins, and the other one is congestion of the veins, i.e. a decreased throughput. Carl already told you what is a dural arteriovenous shunt. They are believed to be acquired, as he has shown, and the consequences of a dural arteriovenous shunt, as I said, can be either impaired venous outflow or cortical venous reflux. And we can differentiate actually between the two of them, both on clinical grounds and on imaging grounds. Now let's first speak about the classical imaging findings. Because of you having a dural arteriovenous shunt, it means that the dural arteries may be dilated on the side of the shunt. So you can see, for example, here that the right occipital artery is slightly larger as compared to the left occipital artery. Or you can see dilated vessels that are present here close to the bone. So dilated ECA branches, a dilated middle meningeal artery as compared to the contralateral side are good clues for a shunt being present. You may be able to see on your bone window transosseous branches. You can see here a cluster of abnormal vessels, and then you see that these vessels, they don't stay out there, they go inside through these transosseous channels. So look for transosseous branches in dural arteriovenous fistula. You can have the so-called shaggy sinus sign. Here we have T1 weighted sequences post-contrast, T2 at the time of flight MRA, and you see that surrounding the blood vessel, surrounding the sinus, we have like multiple small blood vessels that make the appearance of this shaggy sinus sign as a sign for the dural arteriovenous fistula. And of course, if you have cortical venous reflux, then you will see dilated branches without a parenchymal nidus. So you see in this example here, there's no parenchymal nidus. All of the vessels are within the sulci, and this is a telltale sign for venous congestion. Now, if your shunt flow is high, as in this example here, then the dilated vessels are quite obvious. However, if your shunt is relatively low, then the dilatation of the vessels can be more subtle. So here we have a patient, presumably for those of you in the back row, you will not be able to see any difference between the left and the right hemisphere. In this patient, the dural arteriovenous fistula. However, if I blow up this picture, then you can see that on the right side we see normal vessels. We have here MCA branches. That's about it. However, on the contralateral side, there are just too many vessels where we shouldn't have any vessels, and they do have this corkscrew appearance as they cross over the sulci. And this is a sign for cortical venous reflux. Now, T2 weighted sequences are already pretty good. However, T1 weighted post-contrast or susceptibility weighted sequences are much better in order to demonstrate this so-called pseudophlebitic pattern of the venous congestion, the too many dilated, in this case here, transmedullary veins. So look for sulcal vessels. T2 is good, T1 post-contrast is better, but the SWI sequences or T2 gradient echo sequences are definitely the best to demonstrate whether there's evidence for cortical venous reflux. Now, SWI sequences cannot only demonstrate that there are too many vessels, they also can differentiate whether you have arterial reflux or whether you have venous congestion. Now, what SWI sequences can do is they look at the susceptibility that is determined by the oxygen content in your vessels. If you have a high oxygen content, then on your SWI sequences, the arteries or the arterialized veins will appear bright as compared to dark vessels where you have more deoxyhemoglobin, i.e. where you have a congestion of the vessels. And therefore, when you now look at this picture here, you see that we have a dilated vessel here, and we may have a couple of dilated vessels here in the back. This vessel here, just by means of the localization, is the lateral paramesencephalic vein. There is no artery there. And if the lateral paramesencephalic vein has a bright signal, it means it's arterialized. So we know from this picture that we have cortical venous reflux into the lateral paramesencephalic vein. Now, a dark signal in this vessel means that there is less throughput through this area, i.e. we have a traffic jam, we have a venous congestion. So dark signal means venous congestion. So SWI can show arterialization of veins, it can show venous congestion. And here's this patient's dural arteriovenous fistula that was directed indeed into the lateral paramesencephalic vein right there. Here's another example where we can see exactly the same thing. T1 post-contrast, T2, there's a vessel that is a bit too large. There shouldn't be a vessel right there. Cortical veins are here, this vessel doesn't belong there, and this vessel is bright, which indicates that it is arterialized, which means that there has to be a shunt right there. And this was this patient's parasinus or parasagittal sinus arteriovenous fistula, and here are the contralateral injections. What other signs can we look for? When we see distal dilated vessels or focal dilated vessel, you have to identify whether or not this is arterialized or not. You can do this with SWI, but you can also use T1 post-contrast images if you can see a pulsation artifact in the face encoding direction that you can see nicely here, then you know that this structure here has to be arterialized, and you can therefore identify the dural arteriovenous fistula in this case here. So look for focal dilated vessels. Sometimes you just have a focal dilated sinus, as in this example here, but of course we'll need to have then additional findings, such as also dilated MMA. Now here we have a patient who presented with headaches, and when you are looking at these images, what would be your first thought? Well, we have dilated CSF sheaths, we have kinking of the optic nerves, we have dilatation of Meckel's cave, we have an empty cellar here. So all of these images look very much like idiopathic intracranial hypertension. Remember that sometimes the IIH can be caused by a dural arteriovenous fistula. And in this case here, we see a shaggy sinus sign. There are just too many vessels here present. The MMAs are bilaterally dilated. You should not see such a monster MMA here. And so we did a time-of-flight MRA, and indeed there's the evidence for the shunt in this patient that presented with IIH type symptoms. So remember that not everything that looks like IIH is indeed idiopathic. Sometimes you find an underlying cause, and dural arteriovenous fistula certainly are one of the causes for increased intracranial pressure. For the cavernous sinus region, you often see bulging of the cavernous sinus, so there are just too many thick vessels here. And on T2 weighted sequences, that's normal cavernous sinus. Here there are just too many channels within the cavernous sinus, indicating that there should be a fistula here. You can see dilatation of the ophthalmic vein in patients with these types of fistulous location. But what you'll have to look for is whether this dural arteriovenous fistula at the level of the cavernous sinus has reflux or not. So I always look at the hippocampal vein, whether it's dilated, and the sphenoparietal sinus, as these are the two conduits that can lead to cortical venous reflux in patients with dural arteriovenous fistulas of the cavernous sinus region. So look for bulging cavernous sinus, dilated SOV, and look for signs of cortical reflux. In this patient here, he presented as a 43-year-old male patient with progressive cognitive decline. And he was called an outside institution as early microangiopathic changes. However, this is not microangiopathy. This is way too confluent. And if you look carefully, there are abnormal vessels here in the white matter. So when you see evidence for venous congestion, for abnormal bright signal within the brain, think about the possibility of a dural arteriovenous fistula. So a confluent hypotensity on CT or hypersignal on T2 or flare-weighted sequences can be signed for dural arteriovenous fistula with cortical venous reflux. And this patient's symptoms were likely related to the fact that the venous congestion was directed into the medullary veins, leading to kind of normal pressure hydrocephalus type of symptomatology due to hypertension within medullary veins. This patient here came to our attention, actually came to neurosurgical attention for biopsy for brain tumor, and indeed we see a mass-like lesion, maybe here with a small hemorrhage. It's something that was demonstrated as linear enhancement. However, if you are looking carefully, this is not enhancement in the brain parenchyma, this is within the sulcus. So we have here a focal dilated vessel. We have, yes, a focal mass effect due to congestion, but this was another dural arteriovenous fistula. So this is just to show that from an imaging perspective, dural arteriovenous fistulas are great mimickers. They can look like tumors, they can look like trauma, they can look like ABM. They may be completely overlooked from imaging perspective. So their imaging findings are very, can be quite separated. Here we have another example of a case where you can see the hemorrhage, the abnormal vessels, the mass effect, and on first glance it may look like maybe glioblastoma even with or hemangioperisarcoma or hemangioblastoma, but keep dural AV fistula in your list of differential diagnosis. If the dural arteriovenous fistula is redirecting its flow towards the cord, you can present even with myelopathic changes here with cord edema and congestion. Long-standing cortical venous reflux will lead to gyriform calcification, and this was called an outside institution as an incomplete Sturge-Weber syndrome or Form-Fruist or Sturge-Weber syndrome. But again, you see that there are too many vessels here over this hemisphere where we have the focal calcification, and these tram track-like calcifications are signed for long-standing venous congestion or long-standing reflux. Another example here, look at the tram track-like areas of congestion, calcification as a sign for long-standing congestion here with abnormal vessels. Here we have T1 bright signal, petechial hemorrhages can be present in patients with long-standing cortical venous reflux as well. Here you see the abnormal vessels over the right occipital region. In this patient here, we have evidence for shaggy sinus. as well as abnormal cortical venous reflux here on the T2 gradient echo sequences. But what I would like to show here is that this patient had a previous sinus thrombosis. There's no flow void here. And as Carol pointed out, sinus thrombosis can be predisposing for a patient to develop a dural arteriovenous fistula. Here are two different patients, and the reasons why I'm showing them is that both of them have the same pattern of hemorrhage. Both of them have a combination of a subdural hematoma with a parenchymal hematoma. Here's the parenchymal hematoma, and here is a tiny subdural hematoma right there. And in the absence of trauma, the combination of a subdural hematoma with a parenchymal hematoma is a telltale sign for dural arteriovenous fistula, as the parenchymal hemorrhage can be related to arterialization. You can see here a massively dilated pouch in this example of this patient. The subdural hematoma can be present because the abnormal vessels are crossing the dura and therefore can cause both. So therefore always think about this entity if you have a patient who has no trauma. Time of flight MRA. Time of flight will be able to show you the so-called unsaturation of spins, and here we have to briefly dig into the physics of time of flight MRA. What you're doing there is you're putting a saturation band on the top of the head, and all of the spins that are going from cranial to caudal are saturated and therefore will have no signal. As only the spins that go from caudal to cranial will not be saturated and therefore will have a bright signal. Which means that if you have within a venous structure that should get its blood supply from cranial a bright signal, it means that the spins that were coming into this sinus must have come from inferior, therefore indicating that there has to be a shunt present. This only works, of course, on an unenhanced time of flight MRA, and 3 Tesla is better than 1.5 Tesla. We believe a lot in time-resolved imaging, and you can do time-resolved MRA or time-resolved CTA. As in this example here, where already in the early arterial phase, you can see clearly the filling of a vein, venous structure right here, or the MRA in the early arterial phase, where we just have no filling at all of the superior sagittal sinus. We can already see evidence for flow within the transverse sinus, right here indicating an arteriovenous shunt. So to summarize this portion of the talk, imaging findings are very variable in patients with dural arteriovenous fistula. It is truly a chameleon, can be mistaken for a tumor, can be mistaken for other types of vascular malformation, and we just encourage you to keep it in your list of differential diagnosis when you're looking at a patient with kind of a mixed pattern of imaging findings. Okay,